here to present my paper, CSA, entitled Do Informed Consumers Reduce the Price and Prevalence of Counterfeit Drugs? Evidence from the Antimalarial Market. So in healthcare, it's typically characterized by asymmetric information. Patients seek treatment and advice from experts who, in turn, make money from their recommendations. So actually, the private sector is the primary source of care for treatment like malaria and many other so-called simple illnesses. And although asymmetric information is a problem in health markets worldwide, it may be particularly problematic in developing countries due to unregulated markets and low levels of human capital in the average population. This asymmetric information may result in the observed problems we see in the antimalarial drug market, specifically high prices and low quality. And the problem of low quality may not be very familiar, but according to a recent meta-analysis published in The Lancet, as many as 1/3 of antimalarial drugs in sub-Saharan Africa and Southeast Asia are fake, counterfeit, of low quality. And so in this paper, I generally ask the question, if asymmetric information causes problems in markets, will resolving that information asymmetry, so improving customer information, thereby resolve the problems, meaning improve quality and decrease prices? And in the paper, I go through why this is theoretically ambiguous, but you can actually think of it as a price discrimination argument where it could be that people who have more information about their purchases are somehow richer, or it could be the standard Lemons argument where information gives you additional bargaining power or additional information about your purchase and thereby reduces the price. So what I'm going to do is conduct an audit study and test how providers respond to customers who know the diagnosis and or treatment of their purchases and measure the price and quality response. So I'm going to use randomly assigned scripts, and it's really important the type of information that I vary. In particular, the type of information that I vary is information that customers could actually present at the time of purchase and could be taught, as in through an information campaign. I'm then going to link with additional data collected from surveys of vendors and real customers to examine additional mechanisms. And importantly, I'm going to actually have an objective measure of quality in this market. I'm going to test all drugs using a handheld spectrometer and contrast the results of information on drug quality with service quality and correct dosage, which I deem an observable form of quality. And I'm going to briefly present at the end of the presentation my theoretical framework to sort of formalize how this happens, but we might not have time for that. So, and so there's basically 3 reasons why the Ugandan antimalarial market is an ideal setting to test the effect of customer information on the price and quality of drugs. The first is customer characteristics. So although malaria is the most common illness throughout sub-Saharan Africa, there is numerous evidence that customer information regarding malaria transmission, diagnosis, etc., is on average pretty low. And this is somewhat of a puzzle because you'd think people would learn over time, and I don't have a great explanation of why they're not learning, but the information is constantly changing. And this also makes it policy relevant because information campaigns could potentially be a cost-effective way to improve the market functioning, depending upon what the results of the study show. The next reason is that treatment recommendations are not ambiguous. So most other health markets have problems where the patient and the treatment are somehow have to be appropriately matched. So, for example, in cesarean sections, some women are appropriate for cesarean sections, some are not, and it's hard to distinguish those ex ante. Malaria does not have that quality. There's basically one treatment for malaria for everyone, giving a clear interpretation of how providers respond. Finally, the market characteristics allow for a very clean identification of the response of providers to information. There's little enforced institutional regulation. These are fee-for-service providers. There's no insurance, prescriptions, etc. In this market. It's basically if you want a drug, you go up and purchase it. So this is the description of the study. I send in pairs of mystery shoppers to purchase drugs according to scripts And this is the way the scripts went. All shoppers walk into the outlet, greet the shopkeeper, and describe the 4 symptoms of malaria for an uncle or father back at home. And it's an uncle or father to abstract away from issues of pregnancy. The shoppers then either say, I think he has malaria, or what do you think he has, based upon the symptoms. Then the shoppers either say, I want Cortum, or AL, the vernacular, for the first-line treatment, or they say, what do you recommend? Similarly, in the other treatment arm. Then they buy the drug, leave the store, and complete a survey on the transaction before proceeding to the next shop. So one important thing that we did to abstract away from endogenous treatment recommendations is that one concern is that when a provider tells you what they recommend, that could actually change your preferences and what type of drug you want. So we're going to shut down that channel from happening. So all shoppers follow the same drug protocol as listed above. And so therefore, what this is going to result in is basically we're going to have the same types of drugs in each of the treatment arms. So in other words, substituting towards more expensive antimalarial drugs, for example, is not allowed to happen by our protocol. One thing to note is that 92% of visits resulted in a successful antimalarial drug purchase. We had a very low rate of stockouts, but if you actually think about the way the rational use of medicines is supposed to be operating, all of these purchases should have been denied because this is currently not in line with WHO guidelines. So there's basically a rampant overuse of treatment, but that's been well documented in other studies. This is another representation of the study. So basically what I'm going to do is each treatment was assigned with an equal probability. And so these are the observed realizations. And so what I'm going to do is compare conditional mean differences between the control group and all the treatment groups together, having any information, and then also break apart the different treatments separately. So in other words, treatment 1 identifies the effect of a customer who only knows what drug they're purchasing, but still asks for a recommendation. And all cells are observed in data from real customers. So I do think this is realistic. So this is the empirical specification in response to any information, and then again I'm going to break it apart. I'm going to cluster standard errors at the outlet level, and then I'm going to do some other robustness checks to do with standard errors, such as normalized indices to correct for multiple outcomes. And then I also do in the paper an additional multiple outcomes hypothesis standard error correction. So you may be wondering, what exactly does drug quality mean? So at the conclusion, after the survey was completed by the mystery shoppers, the drugs were tested for quality. This is an analysis at the tablet level. So in the top, you can see that this is the Raymond spectra, and this is the result from doing the drug testing. So the black line is the sample from the market, and the red line is the high-quality authentic that I obtained from the manufacturer. You can see that the lines are very close, but they're different enough to be considered different. And so counterfeit in this context should be considered as different, not necessarily low quality. And in fact, that big peak there is one of the active ingredients of the antimalarial drug, artemether or lumefantrine. And so it's really the non-drug parts of the pill, the excipients, the binding agents, etc., that are really making this fail. So in other words, if you compare it to other high-quality samples, it would have matched, because different manufacturers use slightly different combinations of drug dosages and not drug dosages, I'm sorry, but the binding agents and the colorings and et cetera. And so therefore, even though it doesn't match what it's supposed to be, it does match other sorts of brands in the market, and so therefore I'm going to call that not substandard. Substandard can be thought of as literally low quality, unlikely to be medically effective. I find a much higher rate of drug quality in the market than previous studies. I find 17% are counterfeit, 4% are substandard. Let's move on to results. My first result is that while noisy, I find that drug prices fall. So it doesn't matter really how you look at it, but the sample does matter. So I find in the full sample that drug prices fall by about 13% when customers present any information about their purchase. This is sort of in line with our intuitive explanation, potential from the Lemons model. However, when you restrict the sample to the 879 drugs that I could test, I was not able to test all drugs. I'm able to limit some of the variation in the Y variable, and so therefore I'm able to detect a statistically significant decrease of 18 cents. Moreover, this is concentrated most strongly on customers who declare their illness and who do not ask for a diagnosis, although point estimates are overall pretty negative. This is robust to a log specification and to my multiple outcomes index, but I want to proceed with caution a bit because the price effects are not robust to another standard error correction that I do. And so one thing to note is that customers with any information appear to get a better quality of drug. So if you look at some things that a customer might know about their purchase at the time of purchase, two things that they may know about is the correct number of tablets that were in the dosage and whether or not the drug has public sector markings, meaning it's stolen from the public sector. According to both of those objective measures of quality that one could observe, drug quality appears to improve with customer information by both approximately 4 percentage points. So customers with any information appear to be 4 percentage points more likely to receive the correct dosage and are 4 percentage points less likely to receive a drug stolen from the public sector. And these are overall pretty uniform, although in some treatment arms they don't have power. But if you look at actual drug quality actually appears to fall. And so therefore, what I find is that there's no effect on counterfeit drugs, which makes sense potentially because counterfeit drugs are just as effective as the high quality drugs. But I find a decrease in quality by 3.4 percentage points. In other words, customers with information are more likely to buy a substandard drug. And you can see also by the point estimates that it actually doesn't matter if a customer states information regarding malaria or the treatment recommendation, the appropriate drug to choose. Point estimates are all basically the same. This result is very robust. So it's robust to the percentage of pills in the tablet and the dosage that are substandard. It's robust to multiple outcomes hypothesis corrections and other robustness checks that I do. And so one final thing to note is that service quality actually appears to fall. So these are just a few of the checklists. I followed Dawson-Hammer by following a checklist of appropriate behavior. So in other words, do vendors follow what they are supposed to be doing in terms of following the rational use of medicines? And so what I use here is whether or not they express doubts about malaria, ask additional health questions about the patient, and advise the malaria test, all the behaviors that they are, quote unquote, supposed to do. What I find is a pretty strong reduction in service quality, and this might explain, for example, why customers may be reluctant to learn information or present it at the time of purchase, because when they present it, they get a lower quality, people aren't as nice to them, and don't actually treat them with as much effort as one might hope. So to summarize my findings, I find through my audit study that when customers in a market know either the diagnosis or the treatment, they do receive a benefit in terms of price, but there's really important reductions in terms of quality. Importantly, the drug type that they appear to get looks like a better drug. It's more likely to have the correct number of tablets, and it's also less likely to have markings indicating that the drug has been stolen. However, at the same time, actual drug quality falls. And in general, this doesn't differ so much by type of information, but there is a pattern where more information causes a stronger response. And so this might be a bit of a puzzle. And so what I do is I analyze mechanisms through the additional data that I collected, and I develop a theoretical model for analyzing how this happens. So this is the model formally. So what I have here is the provider's profit maximization problem. I determines the type of consumer, and what we have here is providers trying to maximize the price minus the quality minus an effort cost, but they also must consider the future behavior of their the future implications of their behavior on the customers. So there's going to be a limit on how high the price can the price can be that they can charge, and that's going to basically make sure that the consumer agrees to purchase the drug. And so one thing that you will note is that this is supposed to mimic the experimental setup pretty closely. So in other words, because customers walk up and literally reveal their type, they literally reveal information at the time of purchase, the provider is going to be able to perfectly segment the market and therefore charge according to type. And so the problem is solved separately by type, by I. So what we have here is the marginal valuation of service quality is actually the same across both groups. And so what's going to actually dictate the purchase decision is whether or not the customer is likely to come back again in the future. And it's really important to note also that these results all go through if you have different modifications. So one thing you could do is make the valuation of service quality, that theta, vary by type. Another thing that you can do is that this is the outside option. You could also have the outside option vary by type. And this verbally has a really nice understanding that if customers at the point of sale have better outside options with more information, then logically that would also carry over into other periods. And so therefore, if they have other outside options in this period, they would have other outside options in the future periods and also be able to go to that provider less often. Okay, so the constraint finds, provider chooses what drug quality maximizes their profits. The likelihood of returning is positively related to the optimal choice of drug quality. And the intuition behind this is a very different way to characterize information. So in contrast to the Lemons model, information instead signals other characteristics of your demand. And so what you have here is that customers with more information, the informed types, I equals IU, are going to be more likely to receive a low-quality drug. Okay? And so one thing you may ask is, how plausible is this? So what I do is I map the experimental results back into data from real customers. So what I do is I take what real customers did and try to map it into the experiment by putting them into the treatment groups that they would belong to. So what I'm going to say is any information is a customer who reported knowing either the diagnosis or the specific product. And I'm going to control for several characteristics that are in balance across the groups and include a village fixed effect. And what we find is that the experimental results and the observational results are basically the same in sign uniformly, except for the fact that there's a negative selection bias term, which is what we might expect. So in other words, all of these results appear to be the same as the experiment, only stronger in real customers, which gives me some additional credibility. The other thing to note is that there is this very significant difference in the likelihood that the customer has ever purchased from that store before. So in other words, customers with no information are actually more likely to be repeat customers. So this defies the intuition that repeat customers may pay less. Actually, on average, repeat customers pay more, which makes sense because if I'm making a lot of profit off of somebody, why would I reduce the price in the future if they keep coming back? All right, so it's very clear the policy implications. I want to make it very clear that results do not imply withholding information from customers. That's very different. And in fact, there's a pretty sizable price discount from presenting information. But information has limits, and information alone cannot improve drug quality. And this is because providers are strategically responding to the information that customers present and segmenting the market. Because in any sort of information campaign, not everybody's going to take up the information. The people who take up information and present it are on average different than those who don't. And the other important thing is that what's also keeping this market in check is also this service quality. So in other words, people seem to be willing to pay for a good service in this market. It's correlated with price very strongly. And this also may explain why, if customers with information do receive a sizable price discount, how can that gap remain? And it's this quality difference that allows this gap to remain. So in other words, it's not rational for customers to present information at the time of purchase if they are treated, if they don't receive as good of a quality as they would like, in addition to the quality falls. Okay. So in this paper, I conduct an audit study to test the provider response to customer information. I find that presenting information to the vendor causes a decrease in price and profits. Profits are in the paper. Fewer options of additional products and symptoms, also in the paper. I find that service quality falls and also objective measures of drug quality fall, although observable measures of quality seem to increase. And so this is consistent with a model in which vendors segment the market to profit maximize and in some sense use information revealed against customers. So thank you very much.
Many thanks for your presentation and your very interesting paper. It was really interesting, and I really liked the discussion of the different mechanisms and the different explanation. Let me first summarize quickly the paper because not everyone was maybe here during the presentation. So she presented the result of an RCT in which covered shoppers purchase drugs according to two randomly assigned dimensions. So to the dimension according to the scripts the shoppers had to follow. Some of them had to state the patient diagnosis. So I think he has malaria, and the others has to ask for a specific treatment, in this case AL. And she finds that information lower price increase observable drug quality and reduces service and unobservable drug quality. And so she interprets that as a trade-off between short-run benefits of selling a counterfeited drug, which is supposed to be less expensive, and long-run cost of losing a client because he will remark that the drug was of lower quality. And the explanation rely on the assumption that shoppers with information are less likely to be regular clients and so to come back to the same shop. And information also reduces the effort of the seller, meaning that it will lower the price. I have a few questions about the robustness of the results and suggestions. So my first question is, could you add vendor fixed effects? So there were two people coming to each shop to buy some drugs with a different script, meaning that I think you could add vendor fixed effects. I suppose you tried, or there is a reason why you did not do it, and I was wondering why. So the effect on price disappear with more or less with the full sample, but not exactly, and also without outliers. I was wondering whether this is problematic for interpreting the results, and who are these outliers? Could you infer that they were lying on the price? Is it a problem of reporting or something like that? And so could you, explain who are these outliers and what happened when you remove these outliers, and why the price is sometimes way higher for in some shops, in a very few shops, and how this can affect the results or not. And so how the significance change. If you cluster standard error at the village level, you can imagine that there are some characteristics at the village level that are correlated. I have also a few suggestions. So the effect is economically quite small, especially on drug quality, because in fact, drug quality seems quite high, which is great, in fact. And so it seems that a few observations drives the results, at least for drug quality. And so my question was, because you have some effects on different variables, and is the same observation that are driving the results on all these different dependent variables? So can you identify this transaction and show that the transactions that are characterized by a low price are also characterized by a low quality, a low service quality, and so on? So a few observations seems to follow your model, and is it really that these observations have all the characteristics of your model? And I suppose that you could test that by including some variables or interaction variables in the regression, and check whether the significance disappear when you add some interaction variable or some variables in the regression to identify the channel. And what are the characteristics of these few observations? Maybe they have some very specific characteristics that make them different. According to me, but I had only the time to read once the paper, because I learned that I had to discuss the paper yesterday. The concept, the model you presented is interesting, but it's highly dependent on some observation you made, some empirical evidence you had. And so I would present the model after the empirical analysis, as your model relies quite strongly, I think, on the assumption that less information implies that you are more likely to visit the same vendor, and you are more likely to have a higher price. With these two assumptions, you infer that drug quality will be higher when you have less information, and so I would put that after the empirical analysis. I have a few interpretations for lower quality of service. Maybe it's worth discussing that in the paper, maybe it's already done, but information implies that people are less likely to come back. Of course, it implies lower quality. Information implies that people know what they want, so of course there will be less interaction between the vendor and the seller, and so it's logical to reduce marketing, and some of your measure of service quality are in fact just measure of the time, more or less, you spend with the client. And as drug quality is low, profit is high, and so the marginal utility of negotiation is maybe lower. Maybe it's not true, but it's, yeah, I don't know. And then I have a few questions that I had in my mind when I read the paper. So did you expect this result when you did the experiment? And you have 3 treatment arms that have more or less the same, that lead to the same results. And I suppose when you had the idea of this experiment, you wanted to show that there would be different results depending on the treatment arms. And I was wondering, what was your expectation before running the experiment? Are you sure that the sellers know the quality of the drugs they sell? I mean, there are so few bad drugs that maybe they don't really know when they sell bad drugs. And I have plenty of questions on how they are packaged, what are these fake drugs, do they look like other normal drugs, and so on. That's not really important. Why did you do 2 visits per shop? And a question that I think is important, but maybe for further research, why shoppers who know that what they want are less likely to come back to a shop? I think that's an assumption that is quite important in your model, and I'm not sure you try to explain why is it the case, and I would find that interesting, or maybe you have qualitative evidence or an intuition on that. I was also wondering whether people who came with an information are more likely to get the drug called AL, and that this drug is more likely to be counterfeit because it's the most popular one, and so maybe the most produced one. Yeah, also you categorize the fact to get diverted drugs as having lower quality of service. But one could also claim that the diverted drugs are of higher quality because they come from the official channel, from official clinics, and so you are more or less sure that they will be of high quality. And so I'm wondering whether there are, these diverted drugs do not have these two characteristics. And then I have some minor comments, but I will send you the slides by email. But thank you. I found the paper very, very interesting, and thank you for it.
Okay. Thank you so much, and also thank you, Olivier, for reading the paper. You just found out he was discussing it yesterday. So thank you again for that. So there's a lot of comments. I can't address them all right now. So the sad thing that happened in between my pilot and my real study is the interclass cluster correlation coefficient went up a lot in between the pilot and main study. So in the pilot, it looked like I had statistical power to do, to look at differences within a shop, but then it goes up by an order of magnitude several times, actually. So that's why in this paper, it's all actually a market response. And that's why I can talk more about that. It's currently just in an appendix. So the correlates of price are going to be in a separate paper. Sorry, that's why I was trying to separate but then I kind of leave some questions unanswered in this draft. So I find the female, there is some suggestive evidence that females pay slightly higher prices, but it's not robust, so I'm still working on that. But thank you. Yeah, the results are economically small, and so I've been kind of wrestling about how to discuss that, whether or not we would expect information to have a big effect on markets, and I find it actually doesn't. It's one way, but yeah, I agree. Because if you did the elasticity of the price results, it actually doesn't increase demand that much, according to existing estimates. So all my results are statistically significant, but economically small. Negotiating is constant across all treatment arms. The other thing I wanted to say is that I did not expect these results. Again, with the pilot, I had pretty big differences between the pilot and the main study. I also wanted to separate more the exact mechanism, so whether or not it matters if you know malaria versus knowing the real drug. So that's why I did the treatment arms like that. I was anticipating pooling them, but I wasn't exactly expecting this. I was expecting quality to improve, because that's what happened in my pilot. And then actually the last thing I wanted to say is that the drugs with the public sector markings that appear to be stolen from the public sector are actually, it turns out, less likely to be high quality. So either there's potentially corruption as the drugs are being imported into the country, or perhaps counterfeiters have realized that people would assume that these are high quality and are now targeting. Unfortunately, all the results point to a situation where vendors do now, that they're dispensing high-quality drugs, although to generate my results, you don't actually have to have all vendors complicit. It would just have to be a critical mass, knowing that they're knowingly since low-quality drugs. But I can talk more about that later. Thank you.
We'd like to take the comment or question for Annie if you have any questions.
Thank you. That was a really interesting presentation, and I apologize in advance if I missed something. But it seems to me that that there's some important spatial competition factors here. If you go to a vendor and show that you have more information, then that vendor may react differently depending on how many businesses are located close by. So I was wondering if you've looked at that, if you've used like a distance variable to interact with your treatment variable. Also, do you have, anecdotally, do you get the sense that the vendors are cheating based on the price or the quality? Are they really swapping out the counterfeit drugs? And if not, if certain vendors are sort of consistently selling counterfeit drugs, could you use that to get a sense of how much cheating there is going on in the local spatial neighborhood? So that was the question I had. Thank you.
Oh, should I answer? Oh.
Okay. Thanks for your presentation. I have a question about the way in which you designed the experiment. I'm sorry, I've lost the very first slide, so I wasn't here yet. Did you do the experiment like in a big city like Kampala, or did you do it like in small villages where shoppers usually know their clients and suddenly some new clients appear buying anti-malaria drugs? And like, how did you deal with that? Thanks.
Hello? 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 Okay, thank you. So as far as the spatial and competition aspect, I'm actually also doing that in a separate paper. There's a lot of factors that go into determining the price and quality of the drug. I'm just isolating one factor in this paper, which is the customer behavior and the customer revealed type. Prices vary actually double the amount that we have in the US, for example, in the previous study from the US by Sorensen. And so there's clearly a lot going on. There's transportation differences, et cetera. So I use a village mix effect, so I'm not including anything that's related in that sense spatially. I'm restricting my analysis to just within one, in this case, a village. The competition aspects are interesting as well. I'm still exploring that, but that's, I think, a different paper because that would require a different model, more of a general equilibrium model. But that's definitely going on. I think that would have more of a different differential equilibrium effect. I think I got that. And then as far as your comment, oh no, I think it was yours. Are they really swapping out low quality? So actually on the form I recorded where the customer got their drug from, and actually most of the customers with information were more likely to get their drugs from the back. So in other words, it was very strongly significantly more likely that the vendor left the site of the mystery shopper and went to the back to get the drugs. So they do appear to have different stacks of drugs for whatever reason, and that is consistent with the quality results as well. So it does seem like they are substituting quality, and quality is actually, low quality drugs are actually uncorrelated with price. So the actual substandard drugs are not priced differently than real drugs, so most of the action is going to be on the quality measure, not the price measure. And then you asked about Kampala. So the way we did the sampling, it is a stratified random sample, but we don't have all districts. So about half the sample is from Kampala, and half the sample is from other areas. So we were very, very concerned about alerting vendors to the fact that the study was going on and making them suspicious. So we practiced the protocol a bunch of times. We had a very enforced dress code, behavior code. Everything was basically was done to minimize any sort of suspicion from vendors. Even in small areas, there is actually some sort of population that moves through the different areas, whether or not they're banana traders or tourists or whatever. There is some sort of migration happening. And actually, only 6% of my outlets are monopolists. So everybody has some degree of choice, more or less, in terms of where they're shopping. So I don't think it's that unrealistic that vendors are going to know all their customers. I mean, adults get malaria every other year, so approximately in this context. So I don't, and the shops are opening and closing pretty consistently. So I don't think it's, I don't think the model that you always know all your customers is really applicable. But yeah, it's definitely a concern. And I think the main way in which that would have been evident is that if vendors were suspicious of anything, because these are a lot of these vendors are informal sector workers who are evading taxes and things of that nature, they actually would have just closed down. So that was actually what we were most concerned about, is if they were suspicious, they don't risk anything, they just close their doors, and actually the whole entire town shuts down. So I think that's the way it would have been apparent if that would have been in reality, and I don't think it was. We actually did ask on the vendor survey about whether or not they had ever been visited by a mystery shopper, and 11% said yes, but only 3% said a time when it could have corresponded with our survey. But yeah, thank you. I mean, this was a really big concern that we were on high alert for. So thank you.
Okay, thank you so much. If you have a last question, we'll take it, and I would like to move forward. Last question. Okay, so we're gonna move to
my presentation. Thank you. So the paper I will present today is a joint work with Paul Collier and Richard Manning, and it's entitled The Moral and Fiscal Implication of RRT for HIV in Africa. And so you will see that it's a quite different approach that we will follow. It's not RRCT and so on, but I think it has very interesting policy implication. So we will study the economic and the ethical implication of the fact that almost all countries in Africa now are committed to provide free RRT, free therapies against HIV to everyone who needs it. Of course, this has a cost, and the objective of this paper is to study what is the size of this cost and who has to pay for it. We'll see that for some countries, this liability that is created by the commitment of providing treatment to everyone is very large, and because it's very large, it has implication, economic implication and moral implication. I will proceed in 4 steps because we want to derive policy implication. I will first present the ethical framework we chose. In a second step, I will present estimates of this fiscal liability that is created by the commitment of providing RRT to everyone. In a third step, I will show how prevention can be used as an investment to reduce this fiscal liability. And in the fourth step, I will discuss how this liability should be or can be shared between the international community, between donors, and between the country who need help. So the ethical framework, the moral framework we choose is the framework of the moral duty to rescue. And so the usual metaphor to represent this framework is the child that is drowning in a pond, and there is a person passing nearby, and the moral duty to rescue principle states that this person has to save the child if the cost of doing so and the risk of doing so is not too high. There is a moral duty to rescue the child that is drowning in the pond. And we claim in our paper that this moral principle applies to the provision of RRT to those who need it. And why? There are 5 conditions that are fulfilled in both cases. The first condition is that either you provide treatment to persons who are sick, or the person is very likely, almost certain to die. The second criteria is that the treatment should be very expensive for recipients. The third, it should be cheap for donors, which is the case in the for RT therapies, so for HIV. So treatment in sub-Saharan Africa, the cost of treatment will range between $100 and maybe $800 per person who need it per year, which is expensive, of course, in some very poor countries, but which is affordable for the standards of developed countries. And then the fourth condition is limited risk-taking. Of course, if one person jumps in a pond, take a lot of risk, and it's risky to go to save him, the moral obligation to save the person who take unnecessary risk will be lowered. And then the fifth condition is so the moral duty to rescue is generally seen as an individual obligation, but it can also be seen as a global obligation in democracies when a majority of people think that this moral principle is important. What is important is that this moral principle is expected to be less demanding than utilitarian universalism, which is often used by economists. According to utilitarian universalism, you should do like a myriad of redistributive action in order to equalize marginal utilities, more or less. While here, the moral duty to rescue implies a much lower, much less obligation than that. So when we have accepted this moral framework, it has some economic implication. Antiretroviral therapies have the characteristic that it's a lifetime treatment. They have to be provided during the whole life of people as soon as they need it. And once RT is provided, you then have a moral obligation to continue providing these drugs. Otherwise, if you stop providing these drugs, it would be somehow like killing the person. So once RT is provided, there's a moral obligation to continue. This means that when you start providing treatment to someone, it creates a long-term liability because you will have to continue providing this treatment in the long run. And if you aggregate all the long-term liabilities for each person who are infected, it creates a quite large amount of obligation, as we will see, and the analysis of this fiscal obligation is analogous to a long-term obligation, the long-term obligation we have for debt, and that's why in the next slide we'll compare the cost of the long-term obligation of providing RT treatment with the debt of countries that we'll analyze. So in this graph, I represent with the blue bars the external debt stock as a proportion of the GDP, and the red bars are our estimates of the fiscal liability that is created by the commitment of providing RT to all those who need it. To compute the estimate, we use the Spectrum software, which is quite well known in epidemiology, and it's a program that simulate or that model the HIV epidemics. And if you provide some parameters like the different prevention, the coverage of different prevention methods, the coverage of treatment, and so on, it will give you estimates of how many people will need different types of service in the long run. And so we see on this graph that for countries like Lesotho, Malawi, or Zimbabwe, the net present value of this obligation is very high. It represents, for Malawi, for example, 80% of the GDP. Of course, when you compare it to the debt stock, the actual debt stock of Malawi, we see that it's much higher. And so it's macro significant, and it's quite important to take that into account in policymaking. The cost is expected to evolve over time. That's an example for Malawi. It's expected to increase in the short run and decrease in the long run. Why? In the short run, people are getting infected, meaning that given incidence, the cost will rise over time. People survive thanks to antiretroviral therapies and they do not die, meaning that more and more people will need treatment. Also, in fact, people that are HIV positive do not get treatment as soon as they are infected. They get treatment after a period when, after quite a long period, and so in the short run, more and more people that are currently infected will need treatment, and that's also why the cost is expected to increase in the short run, and then decrease in the long run as a percentage when the cost is expressed as a percentage of GDP, because GDP is expected to increase, and because also treatment, and that's something special with antiretroviral treatment, has a preventative effect. In fact, treatment is expected to reduce the transmission rate of HIV by something around 90%, which is quite high. Of course, the estimation of this cost depends a lot on the discount rate that is chosen. Here we have chosen a discount rate of 7%, which is quite high compared to the global health literature. Usually the discount rate that is chosen in global health literature is 3%, and if you consider a discount rate which is higher, of course the cost the net present value of the obligation will be higher. I will explain in a minute why we choose this 7% discount rate. In fact, this 7% discount rate is equal to the marginal interest rate that is faced by the countries, the high prevalence countries, and so that's the price they should pay if they have to borrow to finance this obligation. So in the third step, we were wondering how prevention can be used as an investment to reduce this fiscal liability. And we built a quite simple model, a SI model, which is typical in epidemiological literature, to understand how and at which level prevention we should invest in prevention in order to minimize the cost of this moral obligation. I think I will not have the time to go through all the model, but I will explain the intuition. So in a SI model, there are part of the population that are susceptible of being infected, meaning not infected, and some person who are infected. There are two parents in this model, meaning that some people between the two periods will get infected. Incidence is the share of people that will go from the susceptible category to the infected category. Incidence will depend, of course, on investment and prevention, also on the transmission rate of HIV, which will be different if you get treatment or not. Treatment, as I said, reduces the transmission rate of HIV. There are some parameters characterizing the share of people needing RT and the share of people receiving RT. If they do not get RT while they need it, people die. And of course, prevention and RT as a cost. There is a discount rate, which, as I said, is equal to the marginal interest rate, because to finance the fiscal obligation, people have two possibilities, either to borrow at this marginal interest rate, or to use a surplus of money they have, and they could invest in other type of project, which is expected also to lead to a return that is equal to this marginal interest rate. So whatever the option they have to finance this obligation, we think that the discount rate that should be applied is the marginal interest rate. So if you want to look at the model, you can have a look at the paper. But so what we do in sum is to try to minimize the total cost of the provision of RT and prevention, because we think that's the optimal strategy, of course, for countries. And so we minimize the following objective function, and we obtain the following proposition, that money should be devoted to prevention up to the point at which a marginal dollar spent on prevention reduces the cost of the moral duty to rescue as measured by the discounted cost of treatment by $1. This is quite logical and quite powerful. We also derive 5 other propositions. I will not explain them today, but the most important one are the fact that prevention will be decreasing in the marginal interest rate, and also the fact that with the proposition 4 and 5, we have no, let's skip this one, I will not have time. And so in the paper, we then provide an example on how prevention can be used to minimize the cost of the moral duty to rescue. And we choose one example, which is circumcision, and because it's a quite powerful prevention strategy. And we show, by increasing, using the Spectrum software, by increasing progressively the coverage rate of circumcision, that indeed circumcision can be used to minimize the total cost of RT provision plus circumcision. And in fact, if you do a large initial investment in the short run to increase circumcision rates, an investment of $200 million, it can reduce the net present value of RT provision by $700 million, which lead to a net payoff of around $500 million. So the next question is, who has to pay once we have recognized that there is a moral duty to rescue people who need therapies, and once this cost has been estimated, you remark that it's very large, you try to minimize it with prevention, but prevention, as we saw, is able to reduce the total cost of the moral duty to rescue, but the cost is not reduced by a very, very large amount. And in percentage of GDP, for example, for Malawi, the cost is still, even with circumcision, which is one of the most effective prevention strategy, the cost is still expected to represent 70% of the current GDP. The present value of the cost is still expected to represent 70% of the GDP, which is, of course, considerable. Malawi will have difficulties to pay that alone, and the question we then ask is, who has to pay for financing this moral obligation? And this question involves ethical consideration, economic consideration, and it's of course quite difficult to answer it. But in the paper we propose 4 possible ways of deciding who has to pay what. There exists in the literature some democratic or procedural approach where you put some expert or some people together and you provide them with as many information as you have, and they have to decide together how to apportion the cost, the burden between the international community and the affected countries. Another possibility to share this cost is to base the analysis on debt relief threshold. For example, the IMF has the rule that above 40% of GDP, a debt is considered as not sustainable. And so we can imagine, as for Malawi, that everything that is above a certain threshold, like the IMF threshold for debt sustainability, would be paid by the international community. Another possibility is to look at the behavior of donors and the behavior of the international community as they do currently, and to try to understand what is their real preference. So for example, the Global Fund has a rule for helping countries that are highly affected by HIV that is a mix between criteria about poverty and about HIV burden. So depending on your level of wealth and the level of the importance of your epidemics, the Global Fund decided as a rule that states that you have to pay between 5 to 60% of the amount of the project you want to put in place. And then the fourth approach we propose is really to analyze donor behavior using data and using econometric analysis. And so that's what we did. So to analyze the revealed preference of donors, we ran two sets of regression. In the first one, the dependent variable is the international spending for HIV per capita in recipient country. And so our objective is to analyze how donor funds a project in recipient country depending on their GDP, the GDP of recipient country, and the HIV prevalence in recipient country. In this regression, we see that quite logically, the international community prefer to help countries that are poor and that are characterized by a high HIV prevalence. Then the second question, in order to analyze the capacity of people to finance the response against their own epidemics, is how the capacity to finance this response depends on their characteristics. And so we run this second set of regression in which we assess how the capacity to domestically finance the response against HIV depends on the GDP per capita in the countries, and we see that if the GDP per capita is increased, is doubled, the capacity of domestically finance the response will be also doubled. If we mix these two regressions together, we obtain that kind of figures. And that kind of figures tell you, for example, that countries that are rich and characterized by a low prevalence could, if we base the allocation criteria on revealed preference, should so the proportion of their program that should be paid by the international community should be lower than for, of course, countries that are poor and that are characterized by a high prevalence. In order to conclude, I just want to say, because it's quite important, that we did an extension of the model to 2 players to see, once we have decided how to share this financial this cost between donors and between donors and recipient countries, how to design some rules for the sharing of the cost between prevention and treatment in order for the mechanisms to be incentives compatible, meaning that, and so the first principle that we discuss in the paper is quite important, and in order to avoid moral hazard, we claim that a broadly similar apportionment between countries and donors should be applied to treatment of future infection and prevention. And that's quite logical. If one country is responsible for prevention while the international community will be responsible for financing RT, the cost of RT therapies, of course the recipient country will have no incentive at all to invest in prevention because he knows that he will not have to pay the cost of the financing of treatment. And that's why broadly similar apportionment between countries and donors is needed. In the paper, we discuss how this rule might be affected by the fact that donors and recipients have different discount rates, and so on. To summarize in 10 seconds, so the paper starts from the fact that we have a moral duty, that there is a moral duty to rescue 4 people who need therapies against HIV. It creates a huge fiscal liability, and prevention can be used up to a certain point to reduce this fiscal liability, but not completely, meaning that this fiscal liability will have to be shared between donors and recipient countries, and to avoid moral hazard, a broadly similar apportionment between countries and donors should be applied to treatment of future infection and prevention. Thank you.
Thank you. So thank you so much for your paper. I thought it was really interesting. And I thought what was really kind of cool that we don't see potentially enough in development is using economic theory to make a broader statement about the world and distribution of resources, and particularly the morality. I don't think I've seen morality in an economics paper in some time, and that was, I thought, very refreshing. And so I thought this was a really strong, both economic and moral argument for continuing funding of ARTs from a very different argument than I've heard in the past. And I think that it's really important, he didn't highlight this as much in the presentation, but they talk in the paper about how this argument is particularly strong when the patient has already been started on ARTs. And that's because it actually, they almost equate it to murder. And I think it's a nice reminder of why we study these sorts of issues from multiple perspectives, including a political economy and morality perspective. And so the major comment that I have is that I'm not sure I fully understood everything about the model. And particularly, I didn't really understand about the budget constraint. So, in the model, the main cost is the cost of prevention. But I thought that also, maybe this is just my lack of understanding of this market, but I thought that maybe the governments would have to pay for the cost of actually providing the ARTs as well. Maybe that's all donor funded, and that's why it's not in the model. But then also I felt like we're kind of missing the trade-off in this model. So I think the big question is not that ARTs shouldn't be funded, but it's just that we live in a world with scarce resources, and so there's different ways that we could alternatively allocate the money. And it's not obvious to me that the ARTs are, for example, more important than education, malaria, the malaria market, TB, etc. And then also I think that, I think we're missing the trade-off. And then also, institutions I think are really important here, and particularly corruption when we're talking about massive amounts of donor funding to a given country. And so, in general, I would like to maybe see the government make a choice. Perhaps you can use weights between the funding for HIV as a priority versus other uses. It would make the model more complicated, and perhaps that's why you didn't go in this direction. Models aren't supposed to mimic everything about the real world, but maybe you just work with our intuition. I just sort of said this, but also it's not obvious that we shouldn't invest more in piping infrastructure, housing, roads, continue repeated investments. For example, if you actually look at deaths in the developing world, the number one cause of death is not HIV, but rather, at least among children, diarrheal diseases and upper respiratory diseases. And so perhaps you can motivate more with numbers on the HIV epidemic and economic costs, and what makes HIV so much more costly on a macro scale than those other sorts of uses of money. So the other minor comments is I was a little surprised that there wasn't more resistance. That was, to me, I thought, the major argument for why it is so bad to cut people off of the ARTs, is that it increases the likelihood that they become resistant on a large countrywide scale. That's going to have disastrous implications for our current efficacy of drugs. And then there's not much inherence in the role of individuals into behavior. This ties into corruption and sort of, I think, leads to the external validity of the model. And I think also the current situation is more like a hybrid between the moral argument and zero. So for example, I know in Uganda there's free HIV treatment at public facilities. People queue up, I mean, hours before the public facility opens. So instead, Uganda, for example, is a case where the situation is somewhere in between having continued ARVs for everybody and having nothing. And I think that that's actually possibly common in other countries. And then I also had a minor comment about maybe you could move in a more structural direction. I feel like I'm a very surprising person to make that comment because I love comparing mean differences, and that's my favorite thing to do. But I think like your graphs and your argument, your analysis is sort of going in that direction, but you don't go all the way to a full structural model with simulations and those things. And I just kind of wonder about maybe if you did that, you could introduce multiple periods and introduce more counterfactuals. But I feel like that's a very surprising statement for me. So, do what you want. But thank you very much. I thought it was really interesting and a really cool paper that we don't see a lot.
Thank you. Thank you. I will try to answer a few of the comments, and the other suggestion, I think we'll have to work on that and to think about that, for example, about structural modeling or going a bit further and so on. We'll have to discuss with co-authors about that, and also for the intermediate scenario, for example, which is more in line with the actual situation in countries. That's true that it would be interesting. There are already some papers that are comparing full provision of the cost of full provision of RRT with the cost of continuing the current scenario and so on, and maybe we can just refer to these papers or discuss at least this paper in our paper. And I agree that resistance to drugs is also a good argument in that treatment should be continued lifelong, and that we do not insist on that at all in the paper, and that's a powerful argument. On the model, that's true that there is no budget constraint per se in the model, and that's on purpose, but maybe you raise this question because the argumentation in the paper is not clear, and so that's very useful. There is no budget constraint because we don't want to distinguish between the case where the country will finance the obligation with borrowing or with its own resource. And that's why we use this discounting rate of 7%, which is in Africa more or less the marginal interest rate on borrowing and on alternative investment, like investment in infrastructure and so on. Of course, that's a simplification because in some studies they show that the interest rate on investment in infrastructure can be like 100% or very, very high. And so I agree that's a simplification. And that's why in the paper we try to present some graphs on how the cost evolves with this marginal interest rate. And I agree that we have to be more clear on why we have no budget constraint per se in the model. And I definitely agree that there are alternative use of money, and that's somehow represented in this marginal interest rate. Of course, there are alternative use of money like investment in infrastructure project or something like that, and investment in other disease. And in this paper, we do not want to claim that HIV has some. Yes, we claim that HIV has something special because the cost of treatment is quite high for people who are infected and quite low for the standard of developed countries. For malaria, the cost has to be, the treatment has to be provided lifelong, meaning that for someone who is infected, it's almost, in some countries, it's almost impossible to finance treatment on its own. While for malaria, for example, the cost is like I think in Uganda, $3, something like that, which is high for some families, but affordable. And there, the tension will be, should we invest in this drug or take the risk and hoping that I will be cured alone? And so I think that the moral approach is completely different, and the choice that is, and the possibilities that are available for the person infected are completely different. And that's why, for example, this framework would, according to me, not be applicable to malaria, and that's why we do not take other diseases into account. But for example, there are other diseases that could fit with this framework. For example, diabetes, which is expected to be very prevalent, but in developed countries mainly, but maybe later in developing countries, it can also be applied because it also implies a long-lasting obligation to finance. Thank you for your comments. I don't know if there are any questions. Yes?
Thanks. So I've got 4 comments, but they're hopefully all really brief. So the first one, in your graphs, it was slightly misleading. You said the cost is 80% of GDP of providing ART. It wasn't clear to me. You're comparing 1 year's GDP, but you're comparing the cost of a lifetime of treatment for everyone infected, or you just for everyone infected at that time for 1 year, not taking into account the growth rate? So that's number one. The second is I don't get the discontinuity in the moral obligation once treatment is started. I mean, empirically, it's almost always true that funding is temporarily for some years. If you talk research funding, if you talk scholarship funding for a PhD, it's always, it's usually guaranteed for some time, and then afterwards you just have to figure something out, and you just have to try something new. It's very normal for us, and no one ever talks of a moral obligation that once you start with some sort of temporary funding, you can't stop. So I don't quite get the discontinuity. Let me just third.
I will take notes.
I was slightly missing the economics in the. So I think I agree that it's great to have some ethical arguments in here. I was slightly missing the economic argument of the externalities, and that IRT decreases the infection rate by the infection rate to others by 96%. So we have a very strong economic case for trying to push treatment for one generation, and then hopefully that will manage to eradicate the disease within the next couple of decades, because ART means that people don't really get infected anymore. That's the idea. So I was kind of missing the economic argument in your margins. And then fourth and final, I'm not sure circumcision is such a great example here, because obviously there is a lot of health hazards in that as well, especially when done under not particularly sanitary conditions. And we know all these cases in South Africa which go wrong, where boys die and they lose their limbs, and I'm not sure if it's the best example for that. Thank you.
Thank you. So for the graph, it's the cost, the net present value of the cost of all future obligation compared to the actual GDP. So, and why it can be compared to, so it's the amount you would have to save now, more or less in terms of your GDP, to pay for all the future obligation you will have to provide antiretroviral therapies to all those who need it. And it can be compared to a debt, the level of the debt, because usually the level of the debt is the amount you will have to pay now to fully reimburse the debt. Yeah, and of course prevention and the preventative effect of treatment is taken into account in some way in spectrum. So that's taken into account in the simulation. Of course, the simulation exercise is very complex. It's very difficult to predict the behavior of people. And the objective here is not to say that the cost will be 80% or 100% or 200%, but it's to say that it's very high and that it should be taken into account in budgeting and so on. And it should be I think even if it's difficult, it should be somehow estimated, because it will be a high burden in the budget of developing countries, of donors, and so on. About the moral obligation to continue treatment if it started, of course, people have different moralities, and I suppose that to fully answer your question, we should run a survey to know whether there is a democratic consensus that about the fact that once treatment is started, it should be continued. Another argument, as she said, is that to avoid resistance, treatment should be continued, and I definitely agree with both of you that this argument, two arguments can be put together. For the people who don't believe in the moral argument, they will probably be more convinced by the argument about resistance. RT, of course, reduce in trials the RT when started early in the disease, reduce the transmission rate of HIV compared to when it started later during the disease. Of course, this implies strong positive externalities, which increase again the importance of providing therapies to everyone, and our moral framework also states that we have to provide treatment to everyone. And that this reduction, yes, it's in there. We do not really discuss the externalities, but the externalities play a big role in the model to reduce future infection. But maybe we should discuss more this. It's in the model, but maybe we should discuss it more, and it's noted here. And about circumcision, I'm not an expert in circumcision, but if you have good evidence that it's not the correct prevention strategies to discuss in our paper, I will be pleased to discuss that after the session.
I just had something to add, linking to some of the other comments about prevention, and that is, I was wondering about the epidemiological modeling behind what you were presenting, because we're involved at the moment in a trial in South Africa and Zambia, where they're trying to see what the effects are when you do get HIV positive individuals onto treatment much earlier. So it's a massive project in a contained area, and the idea is to model, but then also to track how that affects the whole life of the disease and infections. And I think it would be, if it's not there currently, important to make that whole emergent literature on earlier, much earlier initiation of treatment part of your model. I think the complications around that is adherence, because if you get people onto treatment at a much earlier stage, theoretically, you have a way to end the disease and to just change the whole profile of the spread of the disease. But then, of course, if you try to motivate that, it's difficult, because then the benefits of compliance are mostly public in terms of the externalities, because at the earlier stages, there are not yet individual negative symptoms of the disease yet. So the compliance and the adherence is very difficult, more difficult to motivate, which makes it interesting economically.
Yeah. No, I definitely agree that adherence is crucial, and I'm starting a new project on this topic, so I hope I will be able to tell you more about that in 2 years. And that's true that providing treatment quite early on has a lot of consequence on the profile of the disease, and it there are large literature now that is emerging on comorbidities and on other diseases, and that will be associated with the fact that people will be lifelong on treatment and so on, and that will have also a cost, which will also be significant, and not in this paper, but I'm part of a big research project on these fiscal issues around HIV, and part of this research project is to take into account and to measure the cost of these comorbidities, but that's some work that is going on, and so we have not been able to include that in the paper yet, but I agree that it's very important. And there are a lot of uncertainties and things that we still don't know about how people really evolve and the health of people evolve when they're on RT. And of course, all the conclusion here will have to be updated when new evidence emerge.
Thanks for that. It was a really interesting paper. Obviously, you had to go quite quickly through the model, so I'll look forward to having a look at the paper itself. But something that's kind of bothering me is thinking about opportunity costs. So as the discussant already raised the issue of kind of alternative uses of that money, and yep, I'm happy that the discount rate, you're kind of building in those trade-offs there. But what I don't think you mentioned, and which would really concern me when we're modeling this kind of thing, would be thinking about with the mortality and morbidity associated with the disease is going to have an impact then on economic activity and GDP kind of aggregated up. And so the most fundamental and important opportunity cost would go through that channel. And I just don't quite see how that's built into the model, whether it could be built into the model or whether it is there, and I just need to read the paper.
Yeah, no, that's a very interesting question. And I've been too fast in the model to indeed be able to explain that. So, as you remarked, morbidity and mortality, the utility loss and the revenue loss and so on of these dramatic events are not taken into account in the model. And that's because of the moral framework we have chosen in the paper. If we had opted for the utilitarian universalism, of course, all losses and all gain from treatment, from prevention and so on, should be taken into account. Here, that's not the choice we made. We decided that we would opt for a minimal framework that would not consider all the losses and all the gain from the different options, but that would only, it's a moral framework that is minimalist and that take into account the fiscal cost that will have to be incurred in the future. Of course, I definitely agree that from a personal point of view, for people who are infected, who are sick, a disease is much more dramatic than that. But in order to reach a minimal threshold of the liability and of the fiscal liability and of the investment in prevention that should be made, that's the choice we made, but I agree that we might disagree on this choice. Yeah.
I'm sorry, because of the time, you can comment.
Okay, sorry. Thank you. Thank you.
Thank you. Okay. All right, thank you so much for this opportunity. I'm Ryoko from University of Michigan. Today I'd like to talk about the relative importance of psychic cost as a potential barriers to vaccination take-up. All right. Okay, so this paper focuses on vaccination because it saves millions of lives every year from different types of diseases. And particularly this paper focuses on tetanus because tetanus is one of the major causes. It's on. It's not on. Hi. So because tetanus is one of the major causes of neonatal mortality in developing countries, including Nigeria, which is my study site. And the newborn baby will usually get tetanus if the umbilical cord is cut with a dirty instrument. So the tetanus toxoid vaccination is the most effective way to prevent the tetanus from the mother as well as the baby. However, the tetanus vaccination take-up is quite low in Nigeria, which is a study site as compared to the world average, which is only 50% as compared to 82%. So the question is why the vaccination take-up is so low in developing countries if the benefit is really high. And previous studies have been identifying potential various barriers, such as monetary costs, or including transportation costs to visit the clinic, or the lack of the information about the importance of the vaccination, or the supply side problems, such as the lack of the supply of the vaccine. But this paper focuses on psychic cost of vaccination. What I mean by psychic cost is that psychic cost is something that is a residual that cannot be explained by monetary cost, such as the fear of a side effect or the fear of the needles. So the previous descriptive studies has been emphasizing the psychic cost, especially in the context of sub-Saharan Africa. For example, polio vaccine boycott that happened in northern Nigeria in 2003 is a famous example. So the Islamic leader in the northern Nigeria claimed that polio vaccine contains some kind of virus that make women infertile or contract HIV. So they should not take it. So that became a big incident. This is a really famous movement. And I just recently found this article from BBC saying that Kenyan Catholic Church claimed that tetanus vaccine is it has some kind of bad intention to hurt the women, so they should not take it. So those kind of movement is really common, and the conventional wisdom, this becomes a conventional wisdom that those psychic costs is a huge barriers to the vaccination take-up. However, the problem is that those descriptive studies have never causally identified the psychic cost as a factor, the causal factor that reduces the vaccination take-up. So I evaluate the psychic cost causally to see if that actually reduces the vaccination take-up or not. And in addition to that, I also examine other potential factors that can affect the vaccination take-up, including cash incentive, disease message that emphasize disease severity, which is called priming, or the social networks. So I implemented the field experiment in Nigeria, the northern part of Nigeria, which is called Jaza local government in Adamawa state. So it's around here. This is a state, and then this is a place where the Boko Haram is quite active these days. And as you can see, Boko Haram has this idea that Western education is forbidden. So as you can see, as a background, those kind of fear or the psychic cost can be quite influential around this area. So I collected a sample from 2,482 women from 80 villages in Jaza within the catchment area of 10 health clinics. The eligibility goes to the women within 15 to 35 years old and those who have never received the tetanus vaccine in the past 6 months. And the priority goes to the pregnant women or those who've never received the tetanus vaccination before. Okay. So this is the descriptive statistics of the sample. So I'll go just quickly. On average, so half of the samples are Muslim, another half are Christian. Like almost another half have never received any type of education. The average earning per capita per day is 1.3, while the transportation cost, which is the bottom, second to the bottom, it costs 40 cents one way, which is like 1/3 of the household income. So it looks quite small, but then if you compare with the earning per capita, then it's actually costing a lot of money per day. Okay, so talking about the psychic cost, this is how I design my research to causally measure the psychic cost. So I randomize a condition under which women can receive the cash reward. There are two conditions. At the clinic, CCT as in conditional cash transfer, or the vaccine CCT. So the women under clinic CCT, they can receive some amount of money if they come to the clinic. On the other hand, the women under vaccine CCT can receive the same amount of money as a woman under clinic CCT if they come to the clinic and then receive the vaccination at that clinic. So then I'm claiming the difference in the clinic attendance under these two different conditions will reveal the psychic cost of vaccination. Why? Because the cost that each of the women under each arm faces a different type of cost. So the cost that women face under vaccine CCT has two components. Transportation cost to come to the clinic and the psychic cost to receive the vaccination. On the other hand, the cost that women face under clinic CCT has only one component, which is transportation cost. Why? Because they can just come to the clinic and they don't have to worry about the vaccination in order for them to receive the money. So the difference in the clinic attendance is going to reveal if the women on average have the psychic cost of the vaccination or not. So this is the empirical strategy that I use, simple LS, because randomization. Why is the clinic attendance? And the vaccine CCT takes one. It's a dummy variable. It takes one if the women are under vaccine CCT who have to come to the clinic and receive the vaccination in order to get the money. The comparison group is the women under clinic CCT who can just get the money as long as they come to the clinic. So if at all the women on average have the psychic cost, then I expect that clinic attendance under vaccine CCT will be lower than those under clinic, those women under clinic CCT. In other words, I expect the better one to be negative. And here's the result. As you can see, it's 0. So clinic attendance for the women, among the women under vaccine CCT is exactly the same as the clinic CCT, a clinic attendance under clinic CCT. That indicates I didn't find that psychic costs are the major barriers to the vaccination. Here's another evidence that psychic costs are actually not the major barrier. This figure is showing the vaccination rate, condition, and the clinic visit. So toward the left, I am showing by the time women come to the clinic, more than 95% of the women decided to take the vaccination, even if that was not the requirement for them to receive the money. So this shows again that we don't have to provide additional cash incentive for women to receive the vaccination. So no psychic costs as a large barriers. So probably some of you might have wondered that my sample is some kind of unique sample that don't have the psychic cost of vaccination. But this table shows otherwise. So I simply asked those women who've never received the vaccination before or who've never taken their children for the vaccination before why that was the case. Then many people actually said psychic costs are the reason why they decided not to come. Psychic costs as in fear of the injection, fear of the side effect, they didn't like the vaccine, and so forth. So this highlights the importance of behavioral intervention experiments instead of just asking why they didn't go for the vaccination. So far, my results shows that psychic costs are actually not the major barriers, on the contrary to the conventional wisdom. But one thing that I cannot rule out within this experiment is this, in the case that I cannot differentiate the psychic cost of vaccination and the psychic cost of the clinic attendance. So if at all women have the similar type of the psychic cost for the vaccination and the clinic attendance, and those people who decided not to go to the clinic no matter which condition they face. But this is something that I cannot rule out in this study. And I'm going to skip this small model. So here I'm briefly introducing about the three other potential factors that can affect the vaccination. One is a cash incentive. So I randomly assign 3 different sizes of the cash incentive to see that if that can affect the vaccination take-up. Another one is a disease message. I randomly assign the type of message, either salient picture, either showing the salient picture of the tetanus patient, along with the oral explanation about the tetanus, or the information that doesn't involve any picture. Finally, I also evaluate the effect of social network with using the 3 units, village, neighborhood, and friends on the vaccination take-up. So this is the overall research design. Toward the top, I've already explained you about the condition for the cash incentive to measure the psychic cost. The second one is the disease message. I randomize the flip chart with or without the picture to scare them or not. And the last one, I have 3 different type of different size of the cash incentive. 5 naira is like 30 cents, almost 0. 300 naira is like $2, and 800 naira is like $5. And then briefly, this is the effect of the size of the cash incentive. As you can see, CCT 300 with the $2 increase the vaccination take-up 17 percentage points, which is quite large, and 800 naira, which is $5, increase the vaccination take-up by 28 percentage points. So this is one example of this primary intervention. Towards the left is the treatment group. So I have several of these pages for the flip charts. We are showing how scary the tetanus can be by showing those kind of picture, while the control group doesn't contain those kind of picture, while the oral explanation about the symptoms and the causes of the tetanus is fixed. And then this is the result for the effect of the priming on the vaccination take-up. As you can see, the effect is 0, which indicates priming intervention does not induce any vaccination behavior. On the other hand, although it didn't induce the vaccination behavior itself, I found that priming intervention actually increased the perceived severity of tetanus. For example, priming increased the number of people they think die because of tetanus, and under priming intervention, they're more likely to feel that they're worried about tetanus, more likely that they feel that tetanus is really bad, or the protection against tetanus is quite important. And furthermore, I also measure the heart rate right before and right after we show those flip charts. And then I found for those who are shown those scary picture, increase the heart rate by 6 beats per minute. So this indicates that those primary intervention actually induce those emotional response, although it didn't induce the behavior itself. Okay, so finally, this is to measure the effect of social network. I am trying to see if the number of the peers who get vaccination increase the likelihoods that I am going to receive the vaccination or not. Because the number of the peers who get vaccination is endogenous, I use the IV strategy, then it's instrumented with the number of peers who are offered the highest amount of CCT, which is random. And then result shows for any units of social network that I use, either village or the 100 meters as in the neighborhood or the friends, all of them positively influence the vaccination take-up, particularly if one additional friend received the vaccination, that increased my vaccination probability by 17 percentage points, which is quite huge. So as a conclusion, I didn't find the psychic cost of the vaccination or the large barriers to vaccination on the control is the conventional wisdom, which is quite surprising. But I found the cash incentives and peers have actually strong influence on the vaccination take-up. So this is the result, and Thank you very much.
Thanks a lot for your presentation again. To go from one slide. It doesn't matter. It doesn't matter. So many thanks for. I will use the keyboard. It's okay. So many thanks for your presentation and the paper. They were both very, very interesting and very, very complete with many robustness check, many discussion, many different treatment, and so it's very, very, very interesting. And so just a short summary of how I understood the paper. So mainly you're saying there is, for the moment, qualitative evidence that seems to suggest that psychic costs of vaccination are high, but in practice what you find in your experiment is that they are not really high, and so you present quantitative evidence that economic barriers rather than psychic costs are responsible for the low vaccine take-up. How you do that? You do a conditional cash transfer RCT, and so you have different treatment groups, of course, and people, there's the result that comforts you in your conclusion that there is no psychic cost is the fact that there's the same clinic attendance in the cash if clinic visit versus the cash if clinic visit plus vaccination groups. And the second result that confirms your intuition is that there are very few people who refuse vaccinations once they are once they are at the clinic. What you also find is that cash transfer are very important to motivate people to come for vaccination, meaning that you interpret that as economic barriers are important. You also find that the importance of friends, neighbor, and village network to motivate testing. So I have a few questions and suggestions and so on. So in your data, it seems that the opportunity cost of going to the clinic is very low. It's on average for area compared to, so the cash incentive that are provided in each groups is 5, 300 and 800 if I remember correctly. And so meaning that first it's not what is surprising is that not everyone goes to the clinic, because when you compare it to this also to the number of people who go to the clinic by walking, and so who face more or less zero cost of going to the clinic. 80% of the people go to the clinic walking, meaning that the economic barriers do not seem very high neither, either when you look at what you measured are the cost of going to the clinic and getting vaccinated. So my question was, is it really the economic barrier that are impeding people for going to the clinic, or is it more procrastination or something else? And so I thought about an alternative explanation that reconciles the piece of evidence, but I'm not sure it's a correct one. So I definitely agree that psychic cost, the monetary value of this psychic cost seems to be lower than 400 naira for most people, except maybe for those who did not come at all to the clinic. But I think that psychic cost and fears can be quite complex. And of course, you can postpone your visit to the clinic because you fear meeting the doctor, getting vaccinated, and so on, and it can induce procrastination. But when you are at the clinic, because of social pressure, because you are in front of health workers or some people, you will not refuse, you will not procrastinate, of course, and you will not refuse to be vaccinated. So I definitely agree that psychic costs are not very high and they are lower than 300, but I think that your experiment cannot rule out that they are still there and inducing procrastination and explaining why people do not vaccinate without incentive. I was also wondering whether the fact that incentives are offered to get vaccinated gives information about the importance of vaccination. I think, of course, you cannot test that, but it can be worth discussing this point. Then I have a few questions that I did not find the answer, I think, in the paper. Why did you choose this amount of money? How interviewers and health staff are paid? Do they have incentive to vaccinate a high amount of people? Or do they have a fixed wage? Do you think that people from the cash if clinic visit may have accepted vaccination because the payment was made at the end of the interview after vaccination, and so they may have feared that if they refused vaccination, they would not have received their payment? And then I have some question about, in some regression, you introduced a transportation cost. Of course, it heavily depends on transportation mode. As we saw, 81% of people come walking, so there is zero cost of going to the clinic. And the cost of going by motorbike is much higher. And of course, depending on the treatment group you have, the transportation mode will be affected. And so I was wondering whether this is a problem to interpret the regression in which you introduce transportation mode in the regression. I was also wondering, how did you choose the categories? Because it's strange that the coefficient associated to the categories with the highest transportation cost is not significant, so you did not see the regression. But so if people have to pay for their transport, it will reduce their propensity to go and get a vaccine, except if they really have to pay a lot. And I found that surprising, and maybe it's because of the way you constructed the categories, I don't know. Or maybe you have another explanation, and isn't it better to use distance, which is maybe more exogenous, but maybe not in fact. Then that's not really important. In the cost-benefit analysis, you include future earnings for unborn children, which can be quite high, I suppose. I'm wondering whether it's usual. I'm not used to do this calculus. And isn't it better to use a measure of the willingness to pay to avoid the death of one child? I mean, because fertility can be adapted, of course, if your child dies because of and so, yeah, I have no answer, but I was wondering. Then I have a few suggestions. Yeah, you don't use or discuss at all the non-random variation in your data, and it can be interesting to discuss it. For example, how take-up is correlated with distance, with opportunity cost, with religion, with education, with wage, and so on. I think in one paragraph you can just give evidence on how this factor influence vaccination and attendance to the clinic. We can discuss later. And yeah, I was wondering whether you interviewed the 26 person who came to the clinic and did not get vaccinated, so who just got the payment without getting the vaccine, because those are the ones who are maybe fearing to get vaccinated, and maybe you can learn a lot by interviewing them, or maybe you I'm sure you interviewed them, and so maybe looking specifically at this 26 person to look at how different they are could be interesting. And similarly, I'm wondering whether you have more information on the 15% of people who did not go to the clinic at all, whether they are different, who they are, and can you give a bit more of information about them. And thank you for your presentation.
Okay. Okay, yeah, I'm just gonna get your comments or question before I move on to addressing his comment, if you have any question.
Thank you very much for your presentation. So I was wondering whether your first results, so the fact that your control group gets contaminated by, and actually you find no difference between the two groups, could actually be reconciled with your social network results, which is, you know, that it's just a matter of diffusion of information. And so the control group, some of them maybe go to the clinic together with some other individuals that happen to be treated, and they talk about this, and at the end they decide to do it together.
Yep.
And so at the end of the day, we're happy about that, actually. I mean, it's not so bad. But I think what really changes then, it's the policy implication of it. And so your social network results, I think it would be interesting to understand whether people actually talk about the importance of getting vaccinated. And so this is why those having a higher share of their peers vaccinated also do so, or if it's rather an income thing. And so they're just telling them, look, you're going to earn a lot of money. I think it's a good thing that you do it. So I think that the policy implication would change a lot. So maybe if you could show the results, not just of the interaction, but also of the single coefficients, that would make us, we could do the difference then of the coefficients and see if it's, you know, what's the content of this information that is going on within the social network.
Okay.
So I think actually Bridget Madrian and some co-authors have a paper looking at the social networks in flu vaccine take-up, in particular with the mechanism that it's nicer for you to be with friends rather than the information diffusion mechanism. And that actually points to just some of the other work in vaccination being that, you know, there is this present cost to it. So if you can offer something kind of nice for someone, you kind of alluded to this mechanism, whether that's social accompaniment or whether it's a little bit of money or whether it's a bag of lentils, it can overcome that present cost. And so that's just one mechanism through which this could happen. And it relates to the second point I had, which was about the interpretation of the voucher. So, and the CCT, how much did people, I don't know how much debriefing you did about how much people thought, some other people have mentioned, that the conditional cash transfer was actually conditional on them getting the vaccination. Because sometimes people do interpret these as being based on vaccination rather than just unconditional.
Okay.
Okay, so I don't really know how this works, but I really thought your presentation was very good, and I identified with it because I like anything on Nigeria, right? So, but then I had a bit of some concerns. One of them is I know for a fact where I come from that there is a lot of interaction with local midwives, right? So I don't know whether this vaccination is given whilst they are pregnant or at the point of delivery, but there is this thing with people from the village. I was from the village once, you know, when I was really young, and we had a thing with people that were you know, schooled. You know, it's a thing where it's us versus them. So I'm more likely to have a good interaction with someone I am used to seeing every day, like a local midwife, than someone in a clinic that has been schooled and is some professional nurse or some professional doctor. So it would be interesting to find out if the subjects in your study, I'm sorry I'm using the word subject, I don't know if it's right, but if they have a lot of interaction with local systems of delivery. So it will be very interesting to find it, because I didn't really see this in your presentation. Maybe you said it, but I don't know. So that can also be the reason why we don't have a lot of moving to, and that might also be the reason why pecuniary incentives is very significant.
Okay. Thank you very much for your comments. So quickly, how many minutes do I have? I don't have any. Okay. So thank you very much for the contamination. So I also did analysis with including the social network, and then I also see if I take into those social network into consideration, and what's going to happen if the main results change, and then I didn't find any change in the main results. So it is true, like everybody in the sample gets some kind of information, then I cannot eliminate this possibility that information diffuse. So yeah, there is some only limited thing that I could do in order to control for the information contamination, but you have a valid point. Social network. Okay, I would like to talk with you after I finish, and then I think it is really useful to get to know more about the literature. So I would like to move on to your comment. So about like the familiarity with the staff, I think it is really an important topic, and then I think that's one of the reasons why I couldn't find the result of the psychic cause. Probably they're the ones who are fearful about the clinic itself, including the vaccination surveys. So I think you have a very valid point, and again, there's limited thing that I will be able to do, because I don't have any knowledge about whether they're familiar to the clinic staff or not, but I think that's something that I should include in my main text. Thank you so much. I will talk to you later. All right, thank you so much for coming. Let me talk with this lady.